Hello friends, I am Dr. Sushil Tahliani, practicing in Mumbai since last more than 35 years, and I find it a very big challenge managing superficial fungal infections, especially the dermatophytic infections. I am sure you also are facing a similar problem at your end. Gone are the days when I saw a patient of Tinea corporis or cruris, I used to find it to be one of the easier consultations. Now I dread to see such patients because I know that I have to be answerable for their recovery, and like all of you, since last 5 years odd, I find more and more cases coming to me who either don't respond well, or even if you have given them treatment for more than 4 to 6 weeks, no sooner have you stopped the treatment and they come back. So today I am going to speak to you about some of the tips of how to use fluconazole in such cases. We all know that fluconazole has been used in studies where it has been approved for use in 1 year and above, and it has been found to be useful and safe even in infants. But there the studies are mainly on its use in candidiasis and sometimes in tinea capitis. So one thing about fluconazole is that we can use it across the age groups. Since it's safe, we can use it even in children. Plus, because even though it may be metabolized by the cytochrome 453F4, the side effect profile is a little better than that of itraconazole. And not uncommonly, we come across patients who have been put on itraconazole and they have not responded satisfactorily. And in one of the studies done across 5 cities and 13 clinics, and which involved 398 cases, we realized that in 70% of patients, the culture shows that the MIC values of itraconazole have touched the maximum permissible levels, and I am concerned because very soon we may lose this molecule if the MIC levels go above the maximum permissible levels. But in many such patients, when we use the fluconazole in the dose of 150 milligrams thrice a week, and in some cases every day, it seems to work better. So this tells me that probably the resistance is not group specific. So those who don't respond to itraconazole may not always not respond to fluconazole, and they may respond to fluconazole. So in such cases where we find it difficult to treat them well, this could be used as a second choice, provided we use it in the dose of minimum 150 milligrams 3 times a week for a period of 8 weeks, and there are studies to document the same. And one last thing about this molecule would be that unlike itraconazole, cost-wise it will be more pocket-friendly, and many of our patients who come to us with dermatophyte infection, they bring the entire families to us, and it becomes a big financial burden for them if you write itraconazole in the course that we normally recommend, and if it's a good brand, and if we decide to give it for 6 weeks, they find it financially challenging, so this would be more pocket-friendly for them. And hence, you would agree with me that in a battle against dermatophytes, which is an uphill battle, if we learn to use this molecule fluconazole judiciously, our armamentarium against the fungus would be a little less incomplete, and we will be able to treat more number of cases successfully. Thank you for your patient hearing.